countries and how they differ around the world. So today I'll be talking about food security in South Africa. South Africa is the country at the southernmost tip of Africa. It has a population of over 58 million people with a life expectancy of around 65 years. The GDP per capita is over $5,000. However, 11% of the population go hungry, and about 27% of all children under 5 have stunted growth, mainly due to malnutrition. And subsistence agriculture is only about 15.6% of the households. So, like with many middle income countries like South Africa, there's a huge paradox in terms of food security. Some of the population suffer from undernutrition and food insecurity, while some of the population suffer from overnutrition as the population moves towards a more Western society, suffering from diseases such as obesity and diabetes. And a very important relationship exists between agriculture and food security. However, the people who are undernutrition um, cannot have their own agriculture because of a lack of resources, a lack of government funding, and a lack of land. So while South Africa may be food secure at a national level, it is very food insecure at the household level. And this has only been exacerbated by issues such as the COVID-19 pandemic, where, where in the graph we see on the side, from 4.3 to 7% was the increase of the proportion of people who experienced hunger. And this was due to strict lockdowns and many people losing their jobs. So food in South Africa is mainly bought. So without jobs, people didn't have income and couldn't buy food, and less reliance on subsistence agriculture because of a lack of resources to produce their own food. In order to combat these problems of food insecurity, the president has planned to eradicate food security over the next 5 years by allocating resources and budget to improving this problem.
So the next country that we are going to be talking about is Haiti. And so next slide. So Haiti is one of the poorest countries in the Americas. They half of their population, in their total population, 10.7 million people, are undernourished. And out of the 188 countries, Haiti ranks 168th in human development. And there are many, many reasons for why Haiti specifically has such a big food insecurity problem and why they're ranked so low in human development. So next slide. So they've had a lot of difficult natural and unnatural disasters. So in 2010, starting from 2010, obviously there's been a lot of issues before that as well, but due to the geographic location of Haiti, they've been struck with a lot of unfortunate natural disasters. So in 2010, there was a magnitude of 7 earthquake that killed 46,000 people and children and 316,000 people. And in 2016, Hurricane Matthew left 806,000 people in need of urgent food assistance. And then in 2019, which was recently, there was a lot of economic and political unrest that pushed 1 million people into really dangerous levels of hunger. And so due to all of these continuous issues, specifically a lot of these natural disasters, it has caused the communities in Haiti and the different towns to have to continuously rebuild their communities and their foundations. And so that has been a huge issue, and that in turn has really contributed to the hunger issues that affect a lot of their population. And more specifically, a really vulnerable population in Haiti to malnutrition and undernutrition is our children. So next slide. So 22% of children in Haiti are chronically malnourished. 10% of them are underweight for their age, and 66% of children under the age of 5 suffer from anemia. And so clearly there are a lot of problems here. And there are also a lot of policies being done to help build some more resilience for Haitians. So next slide. So there's 4 key areas. One are to improve school meals and provide school meals, food for assets, early nutrition, and disaster preparation. So for school meals, there are currently some nonprofit organizations such as the WFP, which is a sector of the UN, and they are the country's largest food safety network. And the government is on track to take over the program by 2030. So thankfully, this is a sustainable program, and they try to source as much food as they can from local farmers. Additionally, food for assets are where participants are given food in exchange for work. So a lot of this work could be on projects such as infrastructure, building roads, dams, irrigation networks, and various different projects that can help improve resilience from the extreme weather that a lot of communities in Haiti face. Then there's early nutrition. So to prevent malnutrition, they provide the UN provides a lot of supplementary food assistance, and there's a lot of work being done in the communities to kind of improve nutrition awareness. And then there's disaster preparation, which is a pretty big one due to the hurricane season and various natural disasters. There's a lot of preparation done to ensure that food resources are in stock, as well as helicopters that make daily deliveries.
So I'm going to be talking about food insecurity in India. Next slide. So a little bit of background is that most of the population is really undernourished, and nearly almost 95 million children and women and adults are undernourished. And India actually shares 1/4 of the global hunger, and it's kind of a big deal because a lot of kids don't actually get a proper nutrition and they're very malnutritioned. And so women really are impacted by the lack of proper nutrition, enough calories. Honestly, they don't receive enough to which later when they have kids, they also when women have kids, their kids are also undernourished, and so it's like kind of like a chain that just keeps going on. And so there are different programs that the government has instituted to help resolve this problem and kind of take care of this. But a lot of the problems have some gaps and loopholes. So most of it is like very inefficient programs. So a lot of people are still undernutritioned. Next slide. So the problem with measuring food security is that even though many research studies take a proper measurement of how much like, for example, over here we talk about high calorie versus low calorie estimates per capita, but the problem is that they're not very accurate measurements. So it really doesn't show how many people are actually receiving a low calorie estimate versus high calorie. So there is a very large uncertainty. So the data that reflects certain the population is very unclear, kind of fuzzy, honestly. But however, we can see that the majority of the population does have a lower calorie estimate versus higher calorie, and generally the low calorie kind of resides in urban areas and rural areas, whereas the high calorie is more in the city lifestyles and other like more richer areas in India. Next slide. So the government has instituted an act called the National Food Security Act, which was in 2013. So this act was basically to enforce the ability for everyone to gain the right amount of food and nutrition. And so they kind of they started off by providing households with food grains when generally they are not when they don't actually have the money to afford such grains. So they legally provide them with the grains, and also they provide about like 5 kilograms of subsidized food grains at a whatever preferred price, which is kind of which it's like 75, it's in effect to 75% of the rural population and 50% of the urban population. Also, the state determines the eligibility of households. So, extra rations are provided to children and women who are pregnant or still lactating. So, it depends on the situation. Also, ration cards is a very big, very important thing in India because it allows a lot of lower class citizens to have the ability to go to certain shops and receive grains or rice, which is kind of like their staple food. Also, so they give these ration cards to women who of the household which are over age 18. So they are allowed to complain and file a complaint against like if the fair shops are not providing a budget friendly, or if it's like not according to the actual the price that it should be, they can file. But however, many citizens are not aware of this due to the lack of education to enroll in certain areas. They also do a computerization of records, keeping track of which family gets this much, and so they try to keep it as organized. This act was signed in 2013, and it's been intact since then. So it has been popular since then, but however, it doesn't reach its full potential of providing nutrition and proper nutrition. It's just like it's the bare minimum, so it doesn't provide them with the nutritional needs that they need to have a healthier lifestyle too. So next slide. The pandemic really impacted the food supply in India tremendously due to a lot of lockdowns. So a lot of people weren't allowed to leave the house and they were stuck at home. So which also caused a lot of the produce to get wasted a lot too in this process, and people didn't have enough food in their homes as they were trying to stock up, but it also led to like food would get spoiled because it wouldn't last very long. So a lot of produce was lost during this time, and local food supply chains were impacted greatly by the pandemic. So small farmers also sold produce like at lower rates than they actually do. So it led to a loss. So a lot of like the economy fell down greatly during this time. So it also impacted a lot of people who couldn't actually get any food, and also leading to a realization that they have a very inadequate system in terms of food supply and how people are in terms of how people are able to the availability of produce and other nutritional needs are for the people. So also during this time, farmers couldn't like travel. So farmers generally traveled to certain areas to help in harvesting and working in farms. And so this wasn't happening. So a lot of basically it was in complete shutdown. So nothing was really working on. So a lot of produce wasn't being produced either. And also there was actually a story where like a bunch of like onions in a truck had actually were stuck rotting during this time because they weren't able to transport the onions to the marketplaces. So it led to a lot huge amounts just getting thrown away and other vegetables. Next slide. Hi. Also, I just we just want so we had a
Hi, Hi, Vandana. Was your presentation wrapping up or did it cut?
I'm sorry. I think so basically what I wanted to add on to there was that one of our team members, Margaret, wasn't able to record in that time. So I just wanted to present that slide that she had. So I was just going to wrap that up real quick for her. Sorry about this. So she wanted to talk about food insecurity in USA. So basically about 89.5% of US households were food secure throughout 2019. But there was an increase about 90% increase in 2018. So households in US were were food insecure, 10% of it during the 2019 time period. And also they really, also it's like 35 million people were living in very huge amount of food insecure households. So household characteristics with most food insecurity was basically like a lot of kids were very undernourished and they weren't receiving the right amount of nutrition even in America. So a lot of people, so this issue with food insecurity is not just a global, not just like a national, like only a certain area on only third world countries, but rather it's a very holistic holistic global perspective that needs to be addressed and taken. Certain measures need to be taken in order to overcome this huge issue and provide proper nutrition, because every individual deserves the right nutritional value foods. And so we really wanted to emphasize that in our presentation. So thank you so much for, thank you.
Awesome. Thank you so much, Vandana, for sharing your team's presentation. Now we'll be transitioning to the Women's Health, Gender, and Empowerment group that will be discussing HIV, COVID, and racial disparities.
Hi, I'm going to be the one sharing my screen. Okay, let me.
Okay, so hello everyone. We are Group 3 and members of the Women Health, Gender, and Empowerment Center of Expertise Student Ambassador program track. Today we're going to be talking about HIV, COVID-19, and racial disparity. And the title that we have today is Same Narrative, but Different Pandemic. Next slide, please. So these are the topics that we're going to delve into. Without further ado, let's get started.
Hi, everyone. Can you hear me? Okay, perfect. Okay, so the first topic of our presentation is current landscape. Next slide, please. Okay, so we're first going to give a quick background on the disease states that we're going to be talking about today, COVID-19 and HIV. So COVID-19 is the ultimate manifestation of infection by the SARS-CoV-2 coronavirus, which broke out in humans at least in December 2019. And I'm a pharmacy student, so usually when I think about disease states, I like to think about what drugs we use to treat those diseases. And so in the case of COVID-19, the first one that we had was remdesivir, which is a very broad spectrum antiviral used for many viral infections, but shown to be effective against COVID-19. And then the second one is a very exciting one. It's called sotrovimab. And this is a monoclonal antibody that was actually just recently approved by the FDA about 2 weeks ago for treating COVID-19, even though it's still an investigational drug. It's very new and it's currently the only monoclonal antibody that we have against COVID-19. And then the second disease state is the one caused by HIV, human immunodeficiency virus. And that can lead to acquired immunodeficiency syndrome, AIDS. And the first AIDS case reported in the US happened back in 1981. And the treatments that we have for AIDS include the ART regimen, the antiretroviral therapy regimen, which usually consists of at least 2 to 3 different antiviral medications. And normally when we think of AIDS patients, we think of people who have compromised immune systems, and typically with vaccines, we want someone who has an intact immune system for them to work. But even that said, according to the National Institute of Health, HIV patients should still receive the COVID shot, regardless of the severity of their disease. So regardless of their CD4 T lymphocyte cell count or the HIV viral load, just because the benefits of the vaccine truly do outweigh the risks of it. Okay, next slide.
Awesome, thank you, Gayane. So now we're gonna talk about how both of these viruses are syndemics when looking at minority populations. So real quickly, a syndemic, if you didn't know, is when we have multiple, 2 or more endemics with very similar characteristics attacking populations at once. So looking at COVID-19 and HIV, so although HIV peaked in the 1980s, it still continues to disproportionately impact Black individuals. And we're gonna talk a lot about the Black community just because their rates are highest, but they're not the only minority group that we will talk about and that are affected pretty disproportionately. And in a recent article, they reported that while representing only 13.4% of the US population, so Black people do not make up a lot of the population, they still account for 42% of new HIV diagnoses and 44% of HIV related deaths. And that was in 2018. So almost 50% of HIV related deaths are coming from the Black community. And similarly, while the Black community does not make up a majority of COVID-19 cases, in COVID-19, they make up the majority of deaths and hospitalizations, which we will look at a little further in the next few slides.
Yeah, so as minorities are more likely to experience negative symptoms of COVID-19, these groups are at a similar disadvantage when battling HIV, and it's very much like a double disparity, or as Sydney just said, is endemic. Therefore, eradication of both HIV and COVID-19 would mean focusing on eradicating these diseases in minority communities specifically.
So this table was taken directly from the CDC, and these are new diagnoses by ethnicity and race. So as you can see, the Black community, Black and African Americans, they make up the most number of new diagnoses, and then following them is Hispanic Latinos, and then white people. So that's just to give you a little visual of what the cases are looking like and how different they are, going from 16,000 African American people and then 9,500 among white people. So it's a very, very, very significant difference.
Yeah, so here we see the rates of COVID-19 cases, hospitalizations, and deaths for 2021. And we can see that the rate ratios are as compared to white non-Hispanic persons. And you can kind of notice that the likelihood for hospitalization and death for minority groups is a lot greater than the number of cases, especially for Black and Latino individuals, meaning that these groups are being hit a lot harder in terms of hospitalization and mortality. So here it just makes me question, like, why are these groups getting hit so hard? Why is there such a big disparity that exists here for minority groups? And what can we do to address this? And what's already being done? So we'll kind of touch on those things in the next few slides.
Okay, everyone. So I'm going to be talking about the policies regarding HIV and COVID-19. Next, please. So one of the important ones is the Ryan White Care Act. This started in 2002, and the main goal of it is to provide funding towards people who don't really qualify for Medi-Cal and Medicare. And majority of the adults in the United States that do not have children or single adults are not qualified for Medi-Cal or like other government insurance programs for healthcare. And so really what it does, it provides like grants to funds towards like local and state programs, especially ones that are more catered towards like specific minorities. So like, as we've seen previously, you know, Black and brown communities are more disproportionately affected by HIV and COVID policies. and thus like their kind of goal is to be reaching more communities in general, especially ones that don't have enough care. And so the program since 2002 has been able to reach over 50% people in the United States. And this is important because it's not just a local kind of like a statewide program, but this is a national program. So the United States has a big population, and reaching about 50% of the people that are diagnosed is a big number for them. And out of those, 87% of the people that are recipients of Ryan-wide care, they've been able to be virally suppressed. So what this means is that they're more in control, or like rather the HIV pandemic has been more in control since like 2002. Next, please.
So ending HIV epidemic initiative was a plan set out for a plan for America. And this is a 10-year initiative that aimed to reduce the new HIV infections in the United States by 90% by 2030. And so there are 4 pillars for HIV epidemic initiatives in the United States. The first one is diagnosis, which seeks to diagnose all people in the United States as soon as possible after infection. Currently, 14% of people in the United States with HIV are unaware of their infection, and 40% of all new HIV infections result from someone who did not know they were HIV positive. The second pillar is treat. To treat people with HIV rapidly after diagnosis, to achieve and maintain viral suppression, also known as being HIV undetectable. So the treatment or HIV for HIV is treatment as prevention. This is when someone, again, as Habiba mentioned, is virally suppressed, which means they cannot transmit HIV to others with proper antiretroviral medication or therapy. The third is prevent. Prevent seeks to use proven prevention interventions to stop new HIV infections occurring, with specific focus on bolstering PrEP uptake. While rates of new HIV infections has slowed since its peak, progress has stagnated in recent years, and racial disparities persist. And the last one is respond. So this focuses on rapidly responding to potential HIV outbreaks to disseminate prevention and treatment services as needed. In part, relies on harnessing public health strategies such as molecular surveillance. Next slide, please. And so in addition, there's COVID-19 policies that most are aware of. And so during the Trump administration, they laid out a few policies. So the first one was the Coronavirus Preparedness and Response Supplemental Appropriation Act. And this act was about roughly $8.3 billion of the US government GDP, which is about 1%, both policies put together. And so this was used to test for the HIV or for COVID-19 virus, as well as transfer to Medicaid funding, develop vaccines and therapeutics, and diagnostics. And it also was used to support the CDC in their response. It also provided like paid 2 weeks paid sick leave and up to 3 months of emergency leave for those infected at about 2/3 pay. Additionally, it provided food assistance and transfers from state funds, expanding unemployment insurance. The second one was the Coronavirus Aid, Relief, and Economic Security Act, known as the CARES Act. This CARES Act was roughly about 11% of the GDP, which is about $2.3 trillion. And this act provided $293 billion to provide one-time tax rebates to individuals. Additionally, it provided $268 billion to expand unemployment benefits, and about $100 billion for hospitals, which we can kind of see that there is a big disparities in treatment through hospitals. The third one that the Trump administration did was the Paycheck Protection Program and Health Enhancement Act. And following when after Trump lost the election and Biden became the new president, the Biden administration released a American Rescue Plan. And so this rescue plan was signed on March 11th of this year, following a year with COVID in the United States, which provided another round of COVID relief or coronavirus relief, which estimated to be about $1 billion or $1.8 billion. And there are also different mandates being placed. So there was the mask mandate as well as the social distancing mandate, which as of this month, many states are starting to lift those and ease the mask mandates and ease restrictions for businesses and activities, except for in government buildings and schools. And there's still some work around that on how that all will lay out come fall. And because of the hesitancy around US citizens getting the COVID-19 vaccine, some states have introduced innovative ways to attract folks to get fully vaccinated. One of those policies or plans is known as the Joints for Jabs, which was introduced by the state of Washington, offering cannabis joints for receiving vaccine shots. And another one was the $50,000 lottery, which was enacted by Governor Newsom in California, entering residents into the lottery for those that will receive full vaccinations. Next slide.
So on to the next topic, we're going to speak about the Positive Women Network organization. Next slide. So who are they? They are a national membership organization of women who are living with HIV. And their mission is to empower women living with HIV in the US and also to develop leadership pipeline and policy agency focused on social justice and human rights. And so noticing that many of the same group of people who are adversely affected by HIV are still the same ones being affected by the COVID-19 pandemic. They have grouped up with other organizations to develop a document with COVID-19 resources for individuals living with COVID-19. Next slide, please. And so to wrap up this presentation, we have here a image, and this image is supposed to reflect love, hope, and peace. And it's very conspicuous that those affected by HIV are the same group that are affected by the COVID-19. And so we do see different pandemic, but the same narrative. This is racial disparity, this is social injustice, and therefore it is necessary that we all do our part to improve the world and make it a better place for everyone. Thank you for listening.
Great, thank you so much for that awesome presentation. We will now be moving on to our next presentation, hearing about how universities can redefine gendered care for QT BIPOC students.
Hi, I will be opening the Google Slides for our group. Thank you for introducing us. Okay. Okay, wait, my sharing screen is not working. Could someone else in our group present?
I can present.
Oh, thank you, Juan.
Yeah, give me 1 second. Can y'all see that?
Yeah, we can.
Okay.
Okay. Hi, everyone. Okay, so this is our presentation, how universities can redefine gendered care for QT BIPOC students. And so our group members are here. I think we'll introduce ourselves as we present our specific portions of the presentation. Next slide. Okay, so this is our table of contents. And so we'll be breaking down our presentation into these 4 different transitions. So our first one is understanding Western ideas of gender and sexuality. Next slide. Okay.
Alrighty, so hi everyone, my name is Sean. My pronouns are he, him, his, and I'll be presenting about the Western model of gender. So traditionally, gender has been constructed within a Western framework that really reinforces binary notions of gender that is really rooted within biological sex. So I'm pretty sure you all have heard of the argument that, you know, sex is biology and therefore science, it is science and therefore it is indisputable. Well, within this binary, we have also constructed sexual orientation and gender expression to stand in opposition to one another, as illustrated in the slides. For instance, for women, we often assign that category to pronouns she, hers, female as the sex assigned at birth, a person's gender expression being, gender identity being a woman, gender expression being feminine, and sexual and romantic attraction being a different gender than self. And likewise for men, the expected pronouns are he, him, the sex assigned at birth is male, gender identity is man, gender expression is masculine, and sexual and romantic attraction is the different gender than themselves. And in this respect, it is clear that our current conception of gender is framed by Western cultural ideas of heteronormativity, of gender and expression that places these identities as static, opposing, and binary categories. And for transgender individuals in particular, these binaries are often complicated, which has historically led to discriminatory, racist, sexist, homophobic, and ableist perspectives, which not only serves to perpetuate the binary, but prevent forming an equitable environment for all people. However, when we talk about equity, and especially gender equity, what does this actually mean? So we can go to the next slide.
Okay, and so this is the definition for gender equity that our group has come up with. So it's equal and or equivalent treatment to opportunities, resources, and needs regardless of gender. And so this is one way of looking at how social norms and power structures impact the lives and opportunities available to different groups of men and women. So for example, in our society today, gender contextualizes and helps define inequalities between these 2 binary groups. So for example, a higher percentage of women enlisted in military are more likely to experience military sexual trauma. And in regards to career opportunities, as we know, there is a wage gap between how much men and women are paid. But contextualizing gender for everyone makes it systemically and structurally difficult for those who don't define themselves under the binary fixed model of gender, difficult to navigate. And so thus, our presentation today primarily focuses on gendered care, specifically to the QT BIPOC UC students. Next slide. Okay, so now we'll be just transitioning into the next part.
Okay, so I'm going to explain some ways that the Western ideas of gender are reflected in the university system. On the right side is the application to change your gender or gender at birth for UCI. They actually don't let you change your gender, even though they have that. They require your birth certificate. For gender at birth, they have non-binary listed instead of intersex. So it really shows how like the university-centric model tends to like focus on legal liability and is really uninterested in like trans and non-binary life. And if they do have some sort of like LGBT center, it is usually underfunded. Universities are branded as inclusive, but it doesn't really benefit trans and non-binary folks. For example, you only see trans folks mentioned in race and gender classes. And normally there's this trans 101 model where trans folks and queer folks and people of color have to explain the issues that affect them. And it's like they have to become the emissaries for something they're not trained to do. Like they're always having to explain and like, yeah, it's not something universities should have to like force them to do. Higher education systems also devalue women's contributions. For example, professors who are women are less likely to get tenure or credit for co-authored publications. And they usually perform more service work if they do become faculty. And it also shows up as well because women are less likely to take leadership roles in STEM and non-STEM fields. And if they do, they usually hold lower level positions and earn less. These usually stem from stereotypes that women are willing to earn less and like willing to take orders. So yeah, universities really lack the support, for example, like maternity and paternity care for working mothers and fathers. And it's like you have to balance your professional life and your personal life. I will now hand it off to Shirelle.
Okay, Shirelle isn't here, so she has very thoughtfully provided some scripts for us to read off of her personal research that she's done. So, so one thing she did research on is the gendered lived name policy, which is an implementation plan by December 31st, 2023, and it's meant to be implemented across all UCs. And so this is kind of the quote that describes essentially what it is going to be implemented for. And so the quote is, "Gender identity is fundamentally personal, and the UC system should ensure that all individuals have university-issued identification documents and displays of personal identification information that recognize their accurate gender identity and lived name." Next slide. Okay, and so this is just a little map of 4 different procedural plans that kind of define how this policy is meant to be implemented tangibly into the UC system. And so the first one has to do with forms. So whether physical or electronic, provided into any person entering the UC system must offer the 3 minimum options when gender information is requested. So that's man, woman, and binary. And next, the gender option selected by any individual within the UC system will be used in all settings and situations. And then next, any individual entering the UC system is permitted to indicate a lived name that in any case that will be used that doesn't require a legal name. And then the last one is basically saying that if any person at any time within their time in the UC system want to amend their records, they should be allowed to do so. And next slide. Okay, and so the significance of this policy to be implemented is that until now, individuals whose gender identity is neither woman or man were forced to choose from just these 2 options. And so within the UC system, being able to offer a non-binary option acknowledges that, binary options are not sufficient enough to recognize gender identity. But could this be made more inclusive? So for now, like Anne mentioned, we only see trans folks mentioned in race and gender classes without any direct interaction or nuances. And as Anne also mentioned earlier, the universities do have LGBTQA plus centers, they are underfunded. So next slide. This just kind of shows to say that in recognition that gender identity is personal, the UCs will allow for more accessibility in terms of displaying one's lived gender and name in official UC documentation. And so this slide just kind of shows the procedures and specifications with the Act, including how individuals can self-identify and how students can more seamlessly change their names to be reflected. And so this is a great first step to expanding the inclusivity of the UC system as it pertains to gender identity and lived name. Okay, next.
And so, hi everyone, my name is Juan Ruiz. I use he, him, él pronouns. And so we decided to include this slide as well because research is very embedded in academia, but we also want to go ahead and acknowledge the fact that research has been embedded with exploitations of BIPOC communities. A lot of the research methods that we know are rooted in white supremacy, and so it's a continuation of that within the university setting. We want to first acknowledge, obviously, that research was started on colonial ideologies, and so one way that we can approach research is through community involvement and community agency, by allowing the communities that we conduct research with to be in full agency and control of what actually is being researched, and therefore not allowing for further exploitation of their trauma. And so we wanted to talk about how transgender and non-binary folks exist in all realms in academia, but yet are not usually included in research analysis that tend to focus more on the gender binary of male-female, as at least that's how research had been framed. And so we have seen that the trans community has identified as non-binary, depending on their identity and their expression, but there's no actual data measuring the impact that these communities have. Research is often very conscious that they're omitting it. It's something that's chosen, although they do know that folks do identify with that. And so that goes back into the slides that we included previously, where when folks are gender nonconforming or trans individuals who do not identify with the binary, they are usually given as unknown. And so that category of assigned as unknown is very dehumanizing in nature, just because it doesn't allow for the full agency of that person to be recognized for who they are. And this is something we continuously see in research studies, where they're usually just binaries, and there's no interdisciplinary or intersectional approach to the different identities that may come about. I also have one of my colleagues here. I'm not sure if Seera is on the call. Okay, I guess not. But so just to continue adding on their part, usually folks who are trans or non-binary always have to fight and advocate for themselves. There's a lot of performative allyship that we see, especially right now during Pride Month, where there's companies who put up the Pride flag. There's different sectors within the university that put up the Pride flag, but yet there's no real action coming from the university settings, where there's funding granted to the LGBTQIA plus resource centers. There's no lobbying that's done compared to other things that are done. So like fossil fuel investment that a lot of universities engage in, there's no actual root net of like funds that can support these students. And so a lot of mental health outcomes can come about from this, especially suicide. And so it's very important to have this inclusive data within all realms of the university and beyond that, because it's literally saving lives and humanizing lives that have been continuously ignored or oppressed by these systems that are based in this cis-het dominance. And so now we're going to be moving into that conversation of multidisciplinary thought of gender, as it's very dynamic and there's always going to be continuations of change in this.
Hi, everyone. So I will be presenting on behalf of Willow. And so we're going to start thinking about how to implement this at an institutional level. Implementing non-gendered or gender-inclusive language in everyday practice. So what does this look like? It looks like using names without titles and pronouns. What does gender-inclusive language mean? It ultimately means to ask people how they like to be referred personally, or just using their name instead of assuming their pronouns. And just as a reminder that this is not just life-changing, but it's life-saving, as it intersects with all other forms of oppression. And also it hopes to mitigate anxiety around the basics of using your name and gender, dealing with possible gender dysphoria, and or the real threat to trans people's mental and physical safety is staggering. Next slide. And then moving on to how can we implement trans inclusive care beyond medical gender affirmation? And this means using correct names and pronouns as a practice, and not just when requested or only when talking directly to a patient. So using it in appointment summaries, when speaking about the patient to other colleagues, voicemails, emails, etc. And also using medical text systems that allow and highlight correct name and pronouns to avoid mistakes, especially in automated messages to the patients. And then finally, using these practices as standard in all medical practices, not just trans specialized practices. Next.
Okay, so for this one, Neha unfortunately isn't able to be here for us, but she did give us a voice memo and her slides just to be able so that she could present digitally. Juan, I think if you exit, I have given sharing access, so it should work now.
Okay.
Give it a try. If
Yeah,
not, I'll.
Yeah, it still doesn't allow me. But I do have their notes since I also worked on a little bit of this in terms of medicine. So I don't know if you want to give it a shot to get the audio going. If not, I can present the slide as well for them.
Yeah, so I should have already shared you the slides. Like, you're an editor now, so you should be able to, if you just exit presenter mode and try again, maybe it'll work and refresh.
Okay.
Thank you for the patience on the technical difficulties, everyone.
Okay, I'm gonna go
Hi
ahead
everyone,
and share
my name is
again.
Neha. I use she, her pronouns, and I just wanted to touch briefly on the institutional changes that I've seen through my experience as
Oh, Juan, I think you muted yourself.
associated with medical mistrust, health disparities focusing on LGBTQI populations, how to take a detailed sexual identity workshop, how to navigate conversations about race, white supremacy, gender equity, how to recognize our own power and privilege, and how to deal with situations where people don't recognize their power and privilege. And very importantly, we've even had a workshop and class on how to implement change and how to advocate for marginalized communities, especially communities that can't always advocate or don't have the power or privilege to advocate for themselves. And while I do realize that this is just a small change, I think this is a big step in moving forward. Like Willow mentioned, not just to have physicians that are dealing with gender affirming care, but to have all physicians overall have an understanding of LGBTQIA health and sexual identity and all the factors that go into medical mistrust and health disparities. I think UCSF is doing a great job of institutional change, and I think this is just a framework for how all institutions should be doing this in the future. Thank you.
So now I'll go over some suggested actions and policy. Next slide. So policies are not enough. There's also a cultural change that needs to happen. For example, this article says that the obstacles are largely because of boys' poor reading proficiency and negative social attitudes towards girls' education. So some suggested actions are to improve boys' reading competencies because these attitudes are instilled in girls and boys at a young age. This is globally as well. So the study was very interesting. They also said that there should be a liberalization of attitudes regarding women's pursuit of higher education. There could also be cultural competency training where educators at all levels examine their own stereotypes and biases towards women in higher education, as well as non-binary folks. Universities really lack the support for, as well as like educators, even though they have well intentions sometimes, they do reinforce these stereotypes. So cultural competency is really something we should be pushing, not only for counselors, but also for teachers and professors. We could also reduce perceived burdensomeness in mental health care. For example, there's a Trevor Project quote that says, "The counseling center at my university had wait times in the order of months, and I didn't want to take away a slot from someone else." So that's something that we should try to improve. And lastly, we can see ourselves as allies in the struggle to distribute resources more evenly across the university. And then if we do that, trans and non-binary inclusion will look very different. We will abandon this trans 101 model where the trans and non-binary folks have to educate everyone around them.
And just to add to that, since we are consistently learning, and even documents and policies now are somewhat outdated with their information, we're moving more to having structural competency, right? Structural competency allows us to understand that the root issues of the conditions of folks are undergoing are dealing with the systems that control and operate and maneuver policies around them, right? And so cultural competency was the prior standard because it allowed us to say, you know, we need to educate ourselves on different factors, but we can never be competent in anyone's experience. And so cultural humility and structural competency are now the new terms that we're going to be using to be able to include that intersectionality that Anne is referring to here as well. And so these are some of the resources that we were able to find. Obviously, there's a lot more. In terms of the National Center for Trans Equality, we put the website link here. And so if anyone would like access to our PowerPoint or any other further resources, we can go ahead and provide those. And so they have a lot of topics being discussed on the site. Know your rights, how to be respectful and supportive for trans and non-binary people. So this is really important with allyship training. Self-help if anyone needs support, and how to be an ally or how to help someone. Online support groups on many platforms through Facebook, Reddit, Discord, trans men of color, for example, and transability. And also research, right? The homonormativity or homonationalism, where a lot of the focus on pride and LGBTQ plus inclusivity focuses on white gay males. And so we're trying to be able to be conscious of that pride is a lot more than that, because at the end of the day, the fight for this did begin through Black trans women and Latinx brown trans women. And so it's very important that we have those discussions of how white supremacy can stem into marginalized groups as well and be complicit of the same system. And so here are our references for anyone that's interested, and we would gladly be willing to talk more about this or share, as some of us are queer individuals such as myself. So if you all have any questions about that as well, I would be willing to share that, or you can just ask us to share the PowerPoint as well. So we want to thank you so much for your time.
Thank you so much for that excellent presentation. And I do want to transition to our next group, and we have 3 more presentations left, and just a friendly reminder to try and stick within the time limit if you can. And so we'll be hearing next on sexual violence, the UC, and the Greek system.
Hi, everyone. I'm going to share my screen right now. Okay. In present mode. There we go. Can you all see? Yeah. Okay, great.
Yeah, I can see it.
Thank you. Okay, awesome. Hi. So first of all, yeah, thank you to all these amazing presentations so far. This has really been so informative and just really engaging. So thank you to all my colleagues for doing such great work. My name's Claire Amabile. My pronouns are she, hers, and I am a member of Group 5. Presenting with me today is Mary Padilla, Grace Nguyen, and then part of our members weren't able to join us, but they are Soraya Costa, Kat Morales, Manju Chinath, Anna Flores, and Selena Isaac. I think I'm pronouncing those right. But today we're going to be talking about an assembly bill, actually, that's right now like in debate. It's called Assembly Bill 524, Campus Recognized Sorority and Transparency Act. And we'll get into kind of the nuances of it, but it's ultimately addressing sexual violence, specifically at the UC, CSU, and community colleges across California within the Greek system. So why does this bill exist? Just to give you all some background, some of you may be familiar with this, but fraternities and sororities are at a pretty increased risk of both experiencing and perpetrating sexual violence, actually. So fraternity members are on average 3 times more likely than non-fraternity affiliated men to perpetrate sexual violence. Very similar, but in an opposite vein, sorority members who are female are more likely to experience sexual violence themselves. And this, of course, is looking in a binary lens at male and female sorority and fraternity members. Part of the reason this happens, well, there's many things that go into why this group is at a unique risk. But one of the main factors that research supports is that they actually, members of Greek organizations consume higher rates of alcohol than their non-Greek affiliated peers. There's a really close relationship between alcohol consumption and risk for both perpetrating and experiencing sexual violence. And this also goes kind of hand in hand with understandings of consent within the Greek community. So fraternity members in general are less likely to seek consent for their partners, and additionally, and more problematically, are more likely to use abusive and manipulative tactics to engage in sexual activities, which really puts them as like an at-risk population again, and one that requires, additionally, fraternity and sorority members have been historically not held as accountable as other groups. Particularly this is because they are typically white, upper middle class, upper class, cis heteronormative people. So they are given a lot of privileges on campus that reflect why they've been able to get away or not held accountable with these actions. So before we get started into the more semantics of the actual bill, to give you just another little background, this bill's goal is really to bring transparency and accountability to the unique culture that is Greek organizations, which allow for such high rates of sexual violence and sexual harassment. And that's the forms of these violences that are occurring within fraternity and sororities. And in doing this, we're hoping to inform students and community members about these sort of occurrences so that they have the ability to make safe decisions with their bodies. And this is done through a sort of scorecard type system. We'll get more into this in 1 second. But basically, this bill would require mandate public disclosures of any accusations of sexual violence among the Greek system. So with that, I'm going to go ahead and pass it off to Mary.
Hi, everyone. Thank you, Claire, for introducing me. My name is Mary, and my pronouns are she, they. So as Claire said, we are focusing on the Greek Act. The Act stands for Accountability, Change, and Transparency. So I'm just going to introduce the 4 main points of the bill. So if passed, it'll require frats and sororities to create annual reports about organization information. The type of information required would be number of members, average GPA, community service hours, and sexual misconduct actions taken against the organization. Universities must also collect information about misconduct from the organization members from groups such as law enforcement, student life, and then compile a report. And then after compiling the report, it must be sent out to all students and made available on school and frat sorority websites. And then the main implications of the bill are, as stated, this bill would hold fraternities and sororities on college campuses accountable for actions of misconduct, especially sexual harassment and sexual assault. The mandated public disclosure of incidents would allow both students and the IFC or the Interfraternity Council to make informed decisions about Greek organizations. The mandated public disclosure would help the IFC conduct internal investigations into the frats and sororities that are perpetuating these unsafe conditions, and also help with the evidence needed to prove the disaffiliations of fraternities and sororities that violate these community guidelines. This bill creates transparency in the Greek life community and should prevent and diminish events of sexual harassment and assault, as well as foster adequate disciplinary actions for frats and sororities that hide or perpetuate instances of sexual harassment and assault. And then while the bill is still currently being passed, it has garnered a lot of support throughout the education in California system, such as from organizations like Students Against Sexual Violence, Free the Period, University of California Student Association, the Associated Students of UC Santa Barbara Human Rights Board, Equal Rights Advocates, Students for Reproductive Justice, and Urge California. And then now I'll pass it on to Grace.
Thanks, Mary. Hi, everyone. My name is Grace Nguyen. My pronouns are she, her, and I will be wrapping up our presentation. So after hearing that information, you may be wondering what is the current state of the bill. The bill was originally known as Assembly Bill 1155, and it was introduced by Senator Rodriguez in 2020. So currently it's known as Assembly Bill 525, Greek Life ACT, standing for Accountability, Change, and Transparency. The bill was heard on the Assembly floor, revised on May 5th, 2021, so about a month ago, and it will be heading to the Senate Education Committee. If passed, the bill is currently set to be active in July 2023, and the first report on members in conduct will be compiled and available on campus websites and through a campus-wide email starting August 2023. So Assembly Bill 524 is a great step in the right direction, but there are more steps that need to be taken in terms of UC policy, UC resources, and community action. So Assembly Bill 525 is a state legislator, so it doesn't necessarily reflect UC policy. There are still very few policies that exist that protect students and provide the necessary resources to protect students from sexual violence or provide trauma intervention or counseling. In terms of UC resources, the UC Center for Advocacy, Resources, and Education does provide access to education resources for students and student groups. And while this service exists, the office only operates during business hours and does not provide immediate counseling or advisory services across all campuses. And since it only operates during business hours, this isn't very accessible to people who need to work or maybe take care of family members, have other commitments during the 9 to 5 typical day. So as a community, we need to help change campus culture and policy. So how can we do that? You can show your support by advocating, educating, and getting involved. So continue advocating for transparency at your university and in Greek life. Advocate for resources in a space where survivors feel comfortable reaching out for support and can have the means to do so. On this slide, we've outlined a couple of organizations that you can get involved in to help end sexual violence across campuses, such as Know Your 9 and Rape on Campus, One Student, the Thriving Initiative, and It's On Us. Another way you can get involved is engaging with online hashtags like Me Too, We As Ourselves, and I Ask. So that concludes our presentation. Thank you for listening.
Thank you so much for that amazing presentation. We'll now be moving on to the harm in SPF group.
Hi, I can go ahead and share my screen. Sorry, can y'all still hear me? It was giving me an error message on my mic.
I hear you. Hi everyone, my name is Mariah and I'll be starting off our presentation, which is the harm of SPF. And it is a case study around the impact of the recent sunscreen bans on low-income communities in Hawaii. And my pronouns are she, her. So just a little overview of what we will cover. We will first cover like the SPF ban and give you all an introduction to the recent policy. We'll provide a cost analysis, which will give you an overview of the different prices of the most popular sunscreens. And we'll also focus on marginalization and the effect of the sunscreen ban on low-income communities in Hawaii. So allow me to just give you an overview of the bill. So it is known as Senate Bill 132, and it would ban the sale of sunscreens in Hawaii containing octocrylene and avobenzene. And if passed, this bill would be enforced January 1st, when passed, it would be enforced January 1, 2023. And it was actually just recently passed a few months ago on March 21st.
Hey guys, my name is Allison, pronouns she, her. So let's talk about why did this ban even come around? Well, chemical UV filters that are commonly found in sunscreens harm coral reefs. They can wash into the environment off of skin, even off of sand or like wastewater, and a harmful dose of these chemicals comes at only 62 parts per trillion, and the common concentration found at nearshore reefs is already 100 parts per trillion to 100 parts per billion. Some of the specific harms of these chemical ingredients to the coral include genetic toxicity, so it can affect the DNA of the coral and disrupt the hormones, which harms reproduction and immunity. It can also cause larval growth deformities. And a big one that I feel like everybody knows is bleaching. So the coral actually has a symbiotic relationship with a specific kind of algae, and the chemicals can cause the algae's photosynthesis mechanism to malfunction, so it no longer provides the coral energy. And the stress of this can actually make the coral expel the algae, ending the symbiotic relationship. So it's bad for both parts. The chemicals also make the coral more temperature sensitive, allowing it to bleach at lower temperatures. With already rising sea level temperatures caused by climate change, this problem is just exacerbated. So overall, it causes colony decline and population destruction.
Now allow me to go into what makes Hawaii's ban unique. So similar sunscreen bans have been enforced in other places, such in Cancun, where they have banned the use of chemical sunscreen specifically near coral reefs. But what makes Hawaii's ban especially unique is due to its scale. It would be statewide, it'd be enforced on every island, and it also has the potential to impact individuals who do not go to the beach or go into the ocean and are actually near the coral reefs, because they would be stopping the selling of these sunscreens all throughout Hawaii.
So why is Hawaii enacting such a strict ban? It's because of the importance of coral to Hawaii. It's a critical ecosystem which protects shorelines from erosion and sea level rise. It's a critical marine habitat for at least 7,000 known species of fish, invertebrates, algae. And there's also the obvious economical and human benefits of tourism and beauty.
So sorry, didn't mean to skip your slides, Allison.
Oh, you're good, I finished.
Our fourth group member, Kamiko, couldn't be here with us, but she went ahead and recorded a voiceover, which I'll go ahead and play right now.
So while certain sunscreens can be damaging to coral environments, they're really important to help reducing the impacts of skin cancer among human populations. So a sunscreen with an SPF of 15 or higher is recommended for everyone to use on a daily basis, while those who are engaging in extended outdoor activities such as hiking or biking, anything like that, as well as those who work outdoors, are recommended to use a sunscreen with an SPF of 30 or higher. It's also been shown that these are effective in reducing the risk of precancer and skin cancers, including squamous cell carcinoma and melanoma. When used properly, these sunscreens can lower the risk for these cancers by about 40% and 50% respectively. This is important as 1 in 5 people in the US develop skin cancer by the age of 70. And approximately 45,000 people die annually from these two skin cancers combined within the US. The graph here on the right shows us how different types of sunscreens can protect against skin cancer.
So with the effects of sunscreen and their ability to mitigate the chances of getting cancer in mind, I will give you an overview of what unequal access to sunscreen. What are the impacts of unequal access to sunscreen? So first off, we have the price. Environmentally friendly sunscreens are often more expensive, which makes them very inaccessible to lower income communities. And they also have huge health impacts, because having less access to sunscreen, as we just talked about in the previous slide, can increase the rate of skin cancer and other health issues, which already at risk in marginalized communities already have a higher prevalence of. And in terms of Hawaii specifically, Hawaii's communities of color and the Native Hawaiians in their indigenous communities are typically the more marginalized and less economically stable communities, and will be more negatively impacted by the unequal access to sunscreen brought on by the recent ban. And just to give you an overview of the actual demographics of Hawaii, most prominently is to note is that there is a 25.5% white population, and their largest population group is Asians with at 37.6%, while Native Hawaiians make up 10.1%, and Black or African Americans only make up 2.2% of Hawaiians. And going into more in depth around the ethnic and racial disparity in Hawaii, it has been noted that newer immigrant groups such as the Marshallese, Tongans, and Samoans are struggling with higher poverty rates, unemployment, and overcrowding in Hawaii. Native Hawaiians also have a higher poverty rate in the state at 15%. And Hawaii's indigenous community has the lowest median household income in the state. And with these economic barriers in mind, it is important to note that economic barriers also pose barriers to accessing healthcare, which leads to more barriers in reference to having no access to sunscreens to combat cancer rates.
So we've already mentioned the importance of sunscreen and also the disparities in sunscreen access, but a huge one that a lot of folks haven't really considered is the price differences. So we did a bit of a cost analysis research project, I guess you can call it. So we went to Amazon, not to endorse Amazon, but it is something that is widely used and accessible to folks in both the mainland and Hawaii. So we just searched sunscreen on Amazon, and these were some of the results that popped up. And as you can see, these are all really big brands that we can find here on the mainland, in Target and Walmarts, online. So Neutrogena, Coppertone, Hawaiian Tropic, Banana Boat, and Sunbum. And out of these 5 that we've sampled per se, only the Sunbum Original SPF 15 is reef safe. And you can see right below the photo on the right that the average price per ounce was about $2.06. And these are just commonly used big brands, as I've mentioned. Now, when you type in reef safe sunscreen on Amazon, you get a completely different family of brands. So Supergoop, folks probably know it's the luxury skincare brand. Kula, Blue Lizard, and Think Sport are all natural-based, mineral-based sunscreens, and reef safe sunscreen is specifically formulated to be safe for reefs. And so these are all would be all able to be sold under the Hawaii ban, but as you can see, since they are of more like luxury and more natural based brands, as a result, they're more expensive, and their average price was about $3.76 per ounce, which is 180% increase. So while you're looking at it per ounce, you're like, okay, well, $1.70 per ounce isn't that significant. If you consider just how expensive a bottle is and how often you're going to be using sunscreen, especially in a state that gets so much sunshine, like it adds up a lot, and it's really disadvantageous to low-income residents of Hawaii, as we mentioned. We also found some relevant studies kind of adding to our findings and our thoughts. So the first study we found was from 2014, and it was a study that looked at counties in 3 counties in Illinois, California, and Florida, and basically cross-referenced high-income and low-income zip codes to see just how much SPF was available, but also the prices. And the really significant finding from that study was that in low-income areas, there was an average of about 20 cents more expensive for sunscreen per ounce than in high income areas. So of course, there's already an economic barrier. Funnily enough, it was easier to find products with SPF 15 and above in low income areas than it was in high income areas. So they don't really know why, but there was more availability. And the second study that we found to kind of build on our results was from 2004, I believe, and it's about 2007, from about socioeconomic status and survival in older patients with melanoma. So we've mentioned that one of the biggest things that SPF can protect you from is a melanoma, and essentially this study occurred in New York, I think across 2 or 3 hospitals, and they found older patients with low incomes had a greater risk for death from melanoma. And of course, this is something that a lot of public health folks already know. Risk of death decreases as your income increases, and especially for non-white communities, this increase is way higher. So going back to the ethnic demographics of Hawaii, a lot of those communities of color are the ones, low-income communities of colors are the ones affected. So it's really significant to recognize the risk for melanoma. So with all that said, we thought it'd be smart/fun to think of some recommendations for policymakers both in Hawaii and also other coastal cities who want to do similar sunscreen bans. So these are a couple of recommendations we have thought about to make the brand more equitable. So first is a voucher program to provide reef-safe sunscreen to lower income communities through vouchers or a credit program so that they're able to buy, especially when they're more expensive. Additionally, we've thought about maybe having academic institutions and government institutions pour more money into research around sunscreen alternatives that are cost effective and sustainable. And you know, mineral sunscreen, we were just talking about this in our group yesterday, is somewhat a newer form of sunscreen being used, not that it's new in the sense of like being discovered, but it's like gaining popularity, especially with reef safety. So maybe there's other, you know, methods or chemicals that are not going to harm our reefs, but are cheaper and sustainable. So having more research around that. Again, another idea is having employer provided sun protection. So especially for working class and low income folks who are in Hawaii and who are using that sunscreen every day, and on, you know, in tourism industries, making sure that employers are mandated to take measures to provide access to reef safe sunscreen is super important. And something that we think should just kind of be given because these are unavoidable circumstances. And finally, just kind of overall hoping that policymakers begin to balance environmental and societal focus in policy creation more, and realizing that, and when you make environmental policies, you are affecting sometimes indirectly, but a lot of times directly, low income communities of color. So making sure to think about them more in their policymaking. And that's the end of our presentation.
Wow, thank you so much for that informative presentation. And we'll now be moving on to, last but not least, our final group on You Are What You Eat, How Food Insecurity Widens Health Disparities.
Okay, I'm gonna share my screen with our presentation. Okay, hi everyone. My name is Kara Pedregosa. My pronouns are she, hers. And here with me today are my colleagues Kelly Song and Pearl Ivanisu. Unfortunately, Claudia wasn't able to come today, but yeah, our presentation is titled You Are What You Eat, How Food Insecurity Widens Health Disparities. And we started off with this phrase, you are what you eat, because while this is a popular phrase, it's very classist because unfortunately not everyone has the ability to control their diet because low income BIPOC communities are disproportionately affected by living in very urban areas that aren't in close proximity to many healthy food options. So they unfortunately don't have the ability to control what they eat as much as other communities can. And next I'll be passing it off to my colleague, Kelly.
Hi, my name is Kelly and my pronouns are she, her, hers. So before we dive into food insecurity and how it affects health outcomes, it's important we define what it means to be food secure. So being food secure means that you have the physical, social, and economic means and access to sufficient, safe, and nutritious food. The key here being nutritious, but we will dive into that bit in the coming slides. So some of the statements a food secure person can make are, I have enough food today. I don't have to worry about getting my next meal today or any day. And I don't have to skip meals today because I have the means to nourish my body, which can be resources, either the expense, the time, and or the access to those food resources. So food secure person can easily get to a grocery store, a farmer's market, or any other food center to replenish. Next slide, please. So moving on, the term food insecure is truly the opposite. It's defined as not having physical, social, and economic access to sufficient, safe, and nutritious food. And there are a variety of reasons a person might be food insecure. So some of these reasons include 1, not having enough funds, 2, poor distribution. So maybe food isn't equally distributed in your region. And if this is the case, you may not even have the opportunity to purchase healthy food because it's not readily accessible in your area. 3, not having a reliable mode of transportation. So if you don't live near a food center and you don't have a car or public transportation, well, you have to get to that food somehow, and it's probably not very often because it's inconvenient and time consuming. 4, location. So maybe the kind of food centers in your area do not offer enough nutritional value. 5, having any sort of conflict in your region. So things like war and crisis can definitely cause major limitations in obtaining food. And 6, structural racism. The very nature of how communities are built is fostered by white supremacy and thus discriminates against communities of color. And this limits options for abundant and nutritious foods. Next slide, please. So another aspect of food insecurity is that it's not just about quantity, but it's also about quality. So for example, one might only have access to processed foods, or they might choose non-perishable items over fresh produce because they need food that is less expensive and will last longer. Continuing on, another term I want to mention is malnutrition, because it's something that often results from food insecurity. And malnutrition is defined as a state of poor health that results from inappropriate caloric intake, over or under, or deficiency in nutrients. All right, now I will pass it off on to my colleague Pearl.
Thank you very much, Kelly. Oh, Claudia is not here today, and she have these two slides that I will be kind of presenting on her behalf. Before we divide into health issue, there are some clarification that we need to make. According to Claudia, she mentioned that the term overweight and obese are often associated with body mass index, measurements that are inherited misleading. The reality is that health is not equal to weight or any body mass ratio. It varies widely across culture. Instead, we want to focus on health outcome that drift from eating an excess of low quality food could lead to a variety of health issues, which include people of all sizes. Next slide, please. Then there are some considerations about food insecurity. Purchasing healthy food like produce means having access to produce nearby, such as special organic. And also, if you live in a food desert, which is an area that is more than a mile from a grocery store, you have to really rely on transportation. If you don't have a private vehicle, let's trip to grocery stores. Next slide, please. Now here you see how she, according to her slide, you see why 42% of undergraduates are food insecure, but various widely by campus. For example, UC Ivon, 62.5%. Food insecurity, according to Claudia, the chart is closer than we think. You see in the pie charts, food security for students, 58%. Low food security for students, 23%. And very low food security for students is 19%. And when you also compare it with these charts here, you see that the cheapest food we can think about is 69%. And 15% is you choose it between paying food or maybe your medicine or other basic need of life. So cheap food is more accessible according to her charts, unlike the healthy food, which will really help you with your health. So if you belong to low community and some underserved community, you can be able to access healthy food. You can go by low quality food or cheaper food, because that's what you can have access to according to your income. Thank you. Now I'll go over to my slide. Next slide, please. Now, I have to talk about the bridge between health and food security. Before I talk about this, we have to know what is health. All along today, we've been talking about health. What do we mean by health? According to Brennan et al., or with the CDC, health is defined as a state of complete health, complete physical, mental, social well-being, and not merely the absence of disease or infirmities. So that one is healthy doesn't mean that you don't have disease. There are other contributing factors to health, which we will see down the line. So one of the fundamental rights of every human being is to attain the highest and enjoyable standard of health, irrespective of your race, religion, politics, economics, and social condition. Also, the health of all people is fundamental to attainment of peace and security, and is depend on the fullness cooperation of individuals and states. This shows that the health of one person or an individual is not basically on her own or his own, but also the state is also accountable for the health of its population. Also, the achievement of any state in the promotion and protection of all is valuable. The states have to be involved, and also protecting one another is very, very important for them to consider in their policy and in their decision making. Also, informed opinions and active cooperation on the part of publics are of the utmost importance in the improvement of health of all people. This means that we have to really educate individuals. We really, through education, either through by going to your doctor primary care or by the school, even the cafeteria, really let people know about the importance of food. In addition, and most importantly, the government has the responsibility for the health of their citizens, which can be fulfilled only by the provision of adequate health and social measures. The government owe it, I feel that the government owe it, especially the government of the United States, owe it to its citizens to provide adequate, quality, healthy food to individual. And that is the basic thing of life. If a government of any country cannot provide for its citizen the basic needs, I don't know how that economy or that country will thrive. Food is a very necessary thing of life, ingredient of life. Without it, I don't think health can be meaningful. Therefore, for us to see how we can bridge the gap between food and between health and food insecurity, if we look at the definition of health, health doesn't mean you cannot be sick. It combines a lot of things to be healthy. Having known what is food insecurity from the above slide from Kelly, we conclude that the difference between health and food insecurity lies on the adequate provision of social and societal determinants of health, which are access to healthy food, access to high-paying jobs, good education, access to transportation system, access to quality insurance, medical insurance, and availability of housing. When you do not have access to food, I don't know how possible you will even have access to housing. All these things are related to one another. When you don't have access to food, it means that apparently you don't have enough money to buy food. And when I'm talking about food, I'm talking about healthy food, quality food that will really nourish your body, not the cheap food that is, according to Claudia chart, was 69%. People can afford it easily. So when you cannot access food, that means you are impoverished. That means you don't even have a good paying job. That means you cannot even have access to good transportation or even access to your medical insurance, including going even to see a doctor or primary care. So for us to really bridge the gap in health, we need to, and our government need to address the issue of social and societal determinants of health, which is the root cause of health crisis in our population. Thank you very much. And I'll pass back the phone to Kelly.
All right, thank you, Pearl. Next slide, please. All right, moving on. Oh, yeah, perfect. Moving on, now that Pearl has discussed the bridge between health and food insecurity, I want to focus on some of the health effects experienced by those living in food deserts or those who are food insecure. So those living on food deserts tend to have a higher rate of chronic illnesses, diabetes, obesity, and cardiovascular diseases. So as mentioned earlier, fresh produce is not as accessible in a food desert, but oftentimes there are a lot of fast food restaurants here, and fast food is often a much more convenient and cheap option. However, there are a lot of negative health effects associated with fast food. Generally, lots of fast food contains many carbohydrates with little to no fiber, which leads to high blood pressure. And over time, this can cause your body's normal insulin production to fail, which can lead to diabetes, obesity, etc. Fast food is also very high in sugars, fats, and sodium, which can lead to cardiovascular issues. Another health effect experienced by those living in food deserts or those who are food insecure is that children with poor nutrition and or chronic illnesses are much more susceptible to social and behavioral issues in school. And being food insecure can also have a negative health, impact on your mental health. And when you add all of these health effects with the fact that many families who are food insecure and or live in food deserts don't have equal access to quality and affordable medical treatment, you have a population who is very disadvantaged health-wise. All right, now I will be passing it off to Kara, who will be talking about solutions.
Okay, so I'll be talking about some potential solutions to help these communities that are really burdened by food deserts and really burdened by the inaccessibility of healthy food. So one way to do this is through community gardens, because they serve as not only a space to get healthy food, but to cultivate social support and emotional well-being too. Because by helping out in community gardens, this gives people an increased sense of control and agency about their diet, which is really what we're trying to solve, because they feel like they have no choice but to eat unhealthily. So this can kind of solve that. And especially during the COVID-19 pandemic, these community gardens have been essential for improving our mental and physical health, because they allow people to connect and socialize even while being socially distant. And while community gardens are not like the end all be all solution to solving food insecurity, they improve access and availability to nutritional food, as well as increasing positive mental and physical health outcomes. And then next, I'll be talking about some solutions that go above like the community scale and onto like the larger societal scale. So one way that we can reduce food insecurity is simply by reducing food waste, because globally about 1.3 billion tons of food is wasted each year, when really that should be going to like the homeless communities or these communities that are burdened by food insecurity. Another potential solution is improving existing infrastructural programs, because food may end up rotting on the way to stores based on poor road infrastructure or storage facilities or problems with the processing equipment. So if we fix those problems, then that would also help reduce food waste. Another solution is to improve trade policies, because corporate giants have commercialized food too much to the point where it's difficult for any small scale farmers to get their products in the market. The next solution is to promote diversification, not only by growing a greater diversity of food, but also educating the community on the importance of a diversified diet. And then lastly, the last potential solution is working towards defeating climate change and farming sustainably, because by farming unsustainably, this really creates even more waste and thus even more food insecurity. But that is the end of our presentation. Thank you everyone so much for listening.